So hello to everyone. We have the pleasure today to welcome Jan Belohlavek from University of Prague here at the ISISM eChat. So hi Jan, pleasure to be
Hello, Fabio. Nice to see you again.
Yes. So the topic today will be a topic that you like, is the use of extracorporeal cardiopulmonary resuscitation, of course, in cardiac arrest. Can you tell us in 2 words what is eCPR for the people that do not know what is it?
Okay, so thank you for inviting me for this chat. eCPR is basically very easy, technically wise. It means that if you are resuscitating a patient, so concerning resuscitation medicine, you're resuscitating a patient and you cannot get the ROSC, I mean, the return of spontaneous circulation. At a certain point, as you know, you have to think what's going to happen within 10, 15 minutes with this patient. And if there is no chance or very low chance of getting a ROSC, we are thinking about eCPR, meaning that we put a patient on a device that will substitute his failing circulation and will try to gain time for other investigations and stabilization and hopefully solving the problem, the cause of cardiac arrest.
When you explain this very easily, people would say, well, that's wonderful because it takes the place of the failing heart, so that should be used in anyone. But which are the recommendations for eCPR in the guidelines?
Yes. As you know, there's been one study published with 30 patients, I mean, randomized controlled trial. And the other study, our study, is under consideration in one of the journals. And there's probably some reason why in past 10 years, nobody has published a randomized controlled trial on that. And despite the fact that they're publishing randomized trials and reading randomized trials every day, and there's a lot of trials ongoing. So, and the reason is that it's actually looks very easily, but in reality, logistic-wise and organizational-wise, it's extremely difficult. And I'm talking about patients with out-of-hospital cardiac arrest mainly. This is completely different population than if you compare this to in-hospital cardiac arrest. As a comparison, if you have a cardiac arrest at a cath lab, so pretty trained circumstances, there is people who are used to resuscitate, there are people who are used to cannulate. There may be very quickly people who are used to work with extracorporeal circulation. And in many cath labs, ORs, ICUs, there is a bedside machines and devices like ECMO, which are standing there, even sometimes pre-primed. So basically no time delays to implement ECMO cannulation and ECMO launching. So in those cases, if we got a cardiac arrest, which doesn't respond to first several defibrillations, let's say, within 10 or 15 minutes, basically all patients are on ECMO. So if it's in the right place, in the right time, it works perfectly well. And out of those patients, 40–50% of them survive nicely, sometimes more if it's done quickly. Why it doesn't work always for patients with out-of-hospital cardiac arrest is obvious. It's a very heterogeneous population, very difficult to pick up the correct patient. And everything has to go step by step very fast. If you lose any minute within those, let's say 30–45 minutes, you will lose your patient, and that's important.
Jan, I think you mentioned, maybe no one is aware of this because no one is interested in the resuscitation field. You mentioned a first paper is already published from Minnesota group. Can you tell us in 2 words what are the main results?
Yeah, sure. This is a RS trial. The main investigator being Dimitris Yiannopoulos, who is a propagator of eCPR in the United States. He works in Minnesota. He's got his Minnesota eCPR protocol, has published several papers in CERC and other great journals. And basically, it's the same what we are doing for past 10 years. He picks up patients with refractory ventricular fibrillation, let people being transported to hospital under CPR, under mechanical CPR, and then if they are appropriate candidates for eCPR, and we can discuss that, he puts them on ECMO. And his results are very similar to ours, actually. And he has shown in non-randomized fashion that almost 50% of his patients are able to survive with a normal neurologic outcome. And it was a non-randomized trial. And then in the randomized trial, which is the RS trial, he has screened 36 patients and randomized 30 patients to ECMO or eCPR arm versus standard arm. And those patients were transported from the field. They came to hospital at about 50 minutes. They were randomized to standard CPR continuation or eCPR. And there were 15 or actually 14 versus 15 patients. It doesn't matter actually. And 6 of those patients who were randomized to eCPR arm survived, versus just 1 patient in the standard arm. And this particular patient had a severe neurological deficit and he died within 3 months. Those other 6 patients in the eCPR arm survived to 180 days post-cardiac arrest. So this trial has been stopped prematurely by the SNB for the eCPR benefit in this particular population.
Because it was too effective.
It was too effective, exactly. And it's kind of extraordinary trial, I would say. But it has definitely shown that in appropriate patients, this actually works.
And as you mentioned, it's more a kind of phase 2 trial because the number of patients is quite limited. And of course, it's not published yet, but you mentioned the Prague study. And you know that you have presented these at the European Society of Cardiology. Can you tell us in few words? Can you tell us in few words the main results of the trial, which is not published yet?
Yeah, as I said, our trial is under consideration in a journal, and but the main results have been published and presented at the ACC. We have randomized almost 10 times more patients than Demetris did. So exactly analyzed 256 patients. And the difference to his trial, and this is, I think, clinically more important, is that we were randomizing patients during out-of-hospital CPR. And our inclusion criteria was a witnessed cardiac arrest, mainly, patients with presumed cardiac cause, patients without ROSC after at least 5 minutes of advanced cardiac life support. But in the reality, this was inclusion criteria. In reality, it was after 15 minutes. Patients were randomized 25 minutes after collapse. So 10 minutes roughly to get on scene, 15 minutes of advanced cardiac life support, and then randomized to eCPR track, or we call it invasive track, versus standard ACLS on site. So those patients randomized to eCPR track, they were put on mechanical CPR, and they had undergone intra-RS transports to hospital. And in hospital, if they were appropriate, meaning that they were still in cardiac arrest and they were not evidently dead, they were put on eCPR, so they were cannulated with ECMO and ECMO was launched. And in these 2 arms, we have seen a trend to better survival and better neurological febrile survival in 180 days. We have seen significantly higher neurological favorable neurological outcome within 30 days. We have seen overall better survival. However, mainly we have seen striking benefit in those patients who didn't get ROSC within 45 minutes and have been resuscitated more than 45 minutes, meaning that this worked perfectly well for patients with truly refractory cardiac arrest, that even after 45 minutes of very appropriate and high quality CPR, they didn't get the ROSC. In this group, we have seen 20 patients surviving in the invasive arm versus 6 patients only surviving in the standard arm. And I have to add that we had an intention to treat analysis in our studies. And out of those 6 patients who were actually counted in the standard arm, based on the intention to treat, 4 of them were crossovers and they survived. So it actually underscores the result of the invasive arm, because if analyzed as treated population, we have seen 24 versus 2 survivors. So there's a highly significant difference.
So Jan, of course, your paper will be out soon, and we know that in Netherlands they've completed the Inception study, which focuses on ventricular fibrillation eCPR. My question is, how do you feel that this results of these studies will influence future practice or future organization? Shall we move for local organization of eCPR centers or eCPR hub, according, of course, to selection criteria, or we are still too far to implement this kind of concept everywhere?
I think we should definitely consider in a proper circumstances, in a proper area, demographic area, this kind of track, so eCPR centers. And the reason is that to define the population, it's basically easy. This is the most appropriate patients for this kind of treatment are patients with ventricular fibrillation who are refractory to initial defibrillation. So at least 3, maybe 4 defibrillation. If they are still in VF, they should definitely at least be considered for eCPR and not losing time. What is important on our trial is that even in those patients who have been transported to hospital, 27% of them, despite the fact they have been randomized during cardiac arrest, 27% of them, they gained ROSC during the transport, first. Second, very high quality CPR on site in the standard group actually resulted in more than 40% of ROSC on site. And those patients who got ROSC either in the standard arm on site or during transport for eCPR, they did the best. So definitely the main importance in resuscitation is to try to reach a ROSC. If it doesn't work, they all died. And this has been nicely shown by Demetrius in his trial. After 50 minutes of unsuccessful CPR and no ROSC, basically nobody has a chance. And we have shown the same, basically. And what is nicely shown also, that is, if we look at our subgroup of patients with VF, ventricular fibrillation, we had almost 50% survival in those patients. And I can tell you, and you are well aware of that, that if we combine the data from ARES trial and Prague trial, and we just take ventricular fibrillation patients, truly refractory patients, we know 2 things. First, they're going to survive in almost 50% cases. First. Second, patients who have a cardiac arrest over 45 minutes and not receiving ECMO, they all die, or basically all of them die. So I think this is a good chance for patients who are in a proper area where eCPR can be provided within 60 minutes of collapse. And from the organizational point of view, this is most important to organize pre-hospital care.
Thanks a lot, Jan, for your very thoughtful insight on this very, very controversial but very interesting topic, and waiting for your results, of course. I hope to see you in the next ICCM chat in the future. Bye.
Thank you very much for inviting me. It was an honor. Thank you. Bye.